Okay, thank you very much for being with us. My name is Salvatore Brugaletta. I'm an interventional cardiologist from Spain and also social media editor from Eurointervention. So I guess that you have been participating to many episodes of Eurointervention Journal on Air. And as you may know, so these sessions are streaming live on Twitter and different social media. And they want to analyze one specific article which has been published on the journal directly with one of the leading authors. As you know, so there is one part when we discuss this article with the author. In the second part, if you have any questions, so just feel free to ask by using the hashtag AIJ on air, and then so we are going to address them. So today, after I would say a long trip, so we succeed to have Giuseppe Tarantini, so Chief of Interventional Cardiology Department from Padova. Thank you, Giuseppe, for being with us. And we invite you to discuss one paper which to me is very important, which has been published on Neurointervention already some months ago, which is about high-risk PCI in patients with reduced left ventricular ejection fraction, who are, of course, not suitable for surgical revascularization. So this is important to say that is a clinical consensus coming from EAPCI together with the ESC working group on cardiovascular surgery. And then, so it's important, that we at least we discuss all together. So thanks again, Giuseppe, for being with us today. And I will start immediately, asking you, so which was the main idea behind this paper?
So thank you. First of all, Salvatore, thank you for having me. It's a bit to your intervention. It's a big pleasure to be here. It has been a long and bumpy road for many reasons, but finally we are here. So the main idea of the paper. So last year it was published, okay, end of the last year. But this was a brainchild of our committee 2 years before. And what was the reason of that? There was at that time no clear guidance existed on what to do when surgery was contraindicated, but revascularization was still appropriate. Based on the myocardial revascularization guidelines, US guidelines, which in case of three vessel disease, symptomatic patient, low ejection fraction, even though surgery is not an option, still remain indicated the revascularization. So in this case, PCI. But in the European guidelines at that time, there was class 1 indication for CABG when there was a very high complexity, while PCI was a class 3 indication. And there was no line to say about the feasibility, to skip this kind of very strict recommendation, 1 against 3, in case of refusal from the surgeons. So there was no defined pathway when surgeons refused to operate. And this was the rationale, and this paper tried to provide a clinical consensus to address the gap, guiding intervention cardiologists on when and how to perform high-risk PCI in patients unsuitable or at very high risk of surgery, the role of multidisciplinary heart team decision-making in these complex patients, and the third point is procedural strategies and technical requirements to achieve a nearly complete or safe, at least safe revascularization in this patient.
Yes, Giuseppe. So to me also, what was interesting when I read this consensus is what, for example, you put in, because when you talk about complex PCI, you always think about the patient and about, complex patient, complex PCI, complex lesions to be treated. But then, so in the figure, so you talk about institutional capability, or for example, long-term care. No, and I was curious, to ask you, so how we may, how these factors actually can influence our PCI or complex patients, and how we may influence them.
Yeah, thank you. I think this is an important point. First of all, the patient identikit. So just to be short, there are patient factors. One of the most important, on top of the coronary complexity calcification or aortic calcification, there is a very low ejection fraction. Very low ejection fraction actually should be an indication for surgery, but when it's associated with three vessel disease calcification and so forth, many times there is a surgical refusal, and this document is a joint venture together with the Surgical Society. The other factor is the kidney disease, severe kidney disease, pre-dialysis or dialysis, and the frailty. Because many times there is no reason when you look at the Optimum trial and you look at the reason for surgical refusal, on top of the absence of conduit, on top of the severe left ventricular dysfunction, patient refusal, things like that, there is 30% of cases where there is the perception of the frailty of the patient to sustain a really, invasive open heart surgery. And, this is the patient factor. Then there are institutional factors. Even though you might say, we refuse the patient from surgery and we turns out to PCI. This is not a normal PCI because you need to be competitive to have a result and to do the things that you need to do in these complex patients. First of all, you need to have to be familiar and to have the availability of mechanical circulatory support that might be preventive, bailout, or provisional. There are different ways, different type of mechanical support. ICU backup. It's very important to have a crosstalk with the ICU. What is also important is the caseload of the operator and the center, because we need to admit there is a very important scrutiny on the result of what we do in this kind of, let's say, ideally indicated for surgery, but refused because of the high risk. So we cannot finish up, with something that is a worse outcome in a hospital, this kind of patient. Finally, the rehab, optimization, medical therapy, and outpatient follow-up. So all these aspects is not just the procedure in the lab, but you need to create a whole path of this very complex patient to deal with the complexity.
Yeah, this is to me a very important comment, no? Because so sometimes so we focus to the procedure, so we think that is a work of one person, but it's not a work of one person, one interventional cardiology, but it's a work of a team, let's say, no? So, and then, so let's talk about the patient. So let's think that we have one patient in our institution that fits perfectly the patient depicted in the consensus. And so we have to consider PCI. So which are the steps that you recommend to consider when we perform this complex PCI in this specific patient?
I think this is the very central question and the most important probably of this document. So the step that we need to consider when we find a patient that matches the one included in this consensus. So first of all, medical therapy need to be optimized. This is very important because when we get a patient in the lab and the patient has an acidosis, 110 of blood pressure without hypoperfusion, this is not a cardiogenic shock. But before starting putting a stent there, we need to correct the acidosis. Probably we need inotropes. So the optimization of medical therapy is the first step to start doing complexity. The second point is to prepare the patient to face this complex procedure. The other things that is very important is to not take a decision by your own, but this patient need to be discussed in the heart team, because you need to have a real surgical refusal, or at least a discussion with the surgeon and the clinician that says, we may do three coronary artery bypass, but the risk is very high, the STS is very high, the mortality might be 15%. So let's figure out if you can do something different that is, doesn't need any deep anesthesiology or things like that. So the heart team is very important for the final shared decision making also with the patient. Then you have to assess, when you decide to go for PCI, the cut complexity, to evaluate, but we will discuss probably later also, the myocardial variability and the need for supported PCI, to anticipate the fact that you may need to study PCI only when you have a myocardial circulatory support in place, and not to put this circulatory support when you have a significant complication or a cardiac arrest. So it's important to figure out, to anticipate, the risk of hemodynamic decay in these patients and to prevent this by means of circulatory support. Then, as recommended in the European guidelines, class 1 is the use of intracoronary imaging, lesion preparation, because a modern PCI, complex PCI, need to finish up with a good result and a good follow-up. So, because there is a scrutiny, and to do that, we cannot be blind. We need to use all the tools that are not tools, are part of the right strategy. They are not just tools to complete to do what we have to do. Finally, we need to target on complete or near complete revascularization, because sometimes we need to be functionally complete, reasonable, anatomically incomplete, but functionally complete revascularization, and plan for post-procedure cardiac rehab and re-optimization of the optimal medical therapy. That is, I think, in different steps, what might be the flow of these patients.
So let's touch maybe, for example, one of these steps that you actually pointed out. So one is the viability. Another one is the mechanical circulatory support. So on one side, for example, talking about viability, so we all know that sometimes viability is difficult, to evaluate. So data are not quite clear. So if a viability is there and we do something, the ejection fraction is going up. So a question for you is, do we need really to have viability in all these patients or not?
So this is a very difficult question to answer. First of all, I need to say something that belongs to the consensus, this consensus. The general agreement is that viability assessment is recommended by consensus as part of the heart team decision, because there are different stakeholders there, surgeons, clinicians, etc., different ideas about that. And actually, they want to start the discussion, also the surgeon mostly, to refuse to accept the patient on the basis of viability, mainly, leveraging the negative predictive value. That means that when you don't have viability, sometimes the surgeon, I'm not saying that this is the right way to go. They prefer to not operate the patient, for instance, if you have a negative viability in LAD. But actually, I'm not saying that I'm in agreement with that. We can, delve deeper in this discussion. But the point is that the predictive value for outcomes remain controversial. We need to admit that because we have different trials. But we know from the revive, in all cases, there was viability that was positive. So all the patients with negative viability were excluded in this trial. So while viability testing might guide the selection of target vessel, mainly for surgeons, evidence of clear survival benefit is inconsistent. We need to admit that. This is the reason why we have a 2B indication also in the European guidelines related to the value of viability when you decide to revascularize. As a matter of fact, mainly in surgical trial like the Stitch trial, the revascularization benefit of CABG was independent of viability and independent of the recovery of ejection fraction. That means that there is something behind, that is the vascular protection that you create and the reduction of sudden death. This is what we know from the past. So the consensus supports aiming for functional complete revascularization, even if anatomical revascularization is reasonably incomplete. And we need to focus mostly on hemodynamic significant lesion rather than all the disease vessel. Sometimes, if this very, let's say, a lesion like in LAD on the circ or a right coronary artery, you have a very dominant vessel. And sometimes you have a negative viability. But this vessel gives the supply with collateral circulation to all the left coronary circulation. Sometimes might be worth to open just to create a kind of vascular protection and, let's say, reverse flow in case of other disease or progression disease in other vessels. These are very complex things, anyway.
It is complex, as you said, but it's important because, not all the patients may fit just one option, no? So that actually is part of the consensus when you say that there is a heart team discussion, no? That is just, as I said at the beginning. So team consensus or more than one person consensus. And second point is mechanical circulatory support. So personally, I like much what you said that when you do it, so please do it at the beginning up front, no? Because otherwise it's too late, no? But my question again, so you know that so we are using a many device, expensive, etc. So we should be using mechanical circulatory support for all the patients, just in few. So how to select the patient who can benefit from this and who can maybe skip, I mean, the use of this device.
So there is for sure MCS should not be routine. Why is that? Because we don't have a final trial, but the final trial that will answer based on some inclusion exclusion criteria is the Protect 4 that has been finished yesterday. So actually, in a short while, we will have, let's say, not a final, but for sure an extremely important answer to this point. It's for selected case for the time being with high risk of hemodynamic compromise that need to be anticipated based on the anatomy, based on a left ejection fraction, on the comorbidity, the length of the lesion, the risk of no reflow, and the fact that you might have a complication that will turn out in a likely severe hemodynamic decay or cardiac arrest, you need to think in advance to put there a circulatory support and should be preventive. We cannot go, like provisional, like the stent, provisional, just in case we have a problem, or as a bailout. Because bailout many times means ECMO, because the patient is in cardiac arrest, you need to oxygenate the patient. You cannot do just with Impella. So Impella is a strategy, is not a device, it's part of a strategy. That means prevent, support, and then to go for PCI. ECMO in this case is not being studied, and actually intra-aortic balloon pump is not effective. So the point is, for the time being, there is also, let's say, an indication also in the new guidelines that circulatory support might be, one way to go, but in a preventive way.
Okay, so we need to wait, as you say, the 1 year. So for the 1 year result of the Protect 4, who actually completed the inclusion yesterday, no?
Yesterday
And
was in a
yeah,
completed enrollment.
yeah. So last question is about one important point to me. So which is the patient perspective, because as always we think about the procedures, the hospital, the doctors, etc. But so we don't talk much about the patient perspective and the family. So and that is to me very important. So do you say anything? So could you say anything on how we should communicate to the patient the risk of the procedure?
Yeah. So I think we used to talk only about the art team. The point is that in a more modern institution, the way to communicate is a second part that is not less important than the heart team. Because in the heart team, sometimes you finish to say with a surgeon that can say, might be feasible, but the risk is very high. So there is not a real surgical refusal. There is a kind of saying that say we need to talk with the patient because the risk is very high, still possible, but the risk is very high. At that point, there is another option. Yes, because now we have a 2B indication in the guidelines. When the risk is very high, we can discuss also about another option that is a PCI. So after the decision of our team that might not be just surgery or PCI, but both based on what? On the second phase, that is the shared decision making. The shared decision making is a very important process now in the FDA. The FDA started with some documents that explain and simplify the way we need to communicate to the patient. First of all, we need to communicate the substantial risk of the two procedures. So when we say with the CABG, probably we have a long-term follow-up that is better. But if the early mortality is 15%, the patient needs to know that. Because on top of the fact that the patient can live for 20 years, the most important part is to get out of the operating room still alive. And this matters a lot to the patient. And one question that used to do the patient is to say, doctor, I don't know if I live 10 years. For me, it's important to live the next 3 to 4 years because I need to fix some problem of my life. So, and we need to be very transparent on that. And the question from the FDA that we need to ask to the patient is, what mattered the most to you when you receive this kind of revascularization, when you have two options? Based on that, we need to take a decision that is very to talk surgeons and intervention cardiology in a fair way to the patient. But at the end, for the principle of autonomy, is the patient that decides what is best for him. Do you understand what I mean? This is very important. So we need to explain the realistic potential benefit of the procedure if it is at long term, but what is the risk at short term? And what
Yes.
is the alternative of that? Including optimal medical therapy and palliative care when the patient is too frail. And an open, clear communication is very key. So specific phrasing guidance is not detailed, but now we've published, I think for the people connected, there is an official paper on the American Journal of Cardiology that we published together, interventional cardiologists, heart surgeons, and medical legal forensic doctors. It is the joint venture of three parts: the legal part, surgery, intervention, cardiology. First name is Giuseppe Tarantini. That you can read it. They fix the rules, how to talk and how to rule the shared decision making for the patient.
Okay, thank you, Giuseppe. I guess that so we touched, I mean, most of the points of the paper. So about the different factors which can influence the PCI. So which the patient and how we may consider this patient with the different steps. Then so you talk about viability, mechanical circulatory support, and last but not least, the patient perspective. As I said, it is very very important. I guess that there are no questions from the audience. So let me check. Yes, there are no questions. So I will actually close the session. So thank you very much, Giuseppe. I guess it was really great discussion. So
Thank you
I
very much.
also thank the community, the our intervention staff who made possible, I mean, all these live session. And so this session will be replayed and you can enjoy later on. So on different social media. So thank you very
Anyway,
much.
it's my privilege, and I would like to commend all of you, your intervention, you for the great job that you are doing for the community. Congratulations.
Yeah, and actually, the last, thing that we have, last news is that every intervention has increased the impact factor. So it was just mentioned by Davide Capodanno a few minutes, ago. That is also good, to celebrate with the community and also with this paper.
How
So
much is
thanks,
that
Giuseppe.
now? How much is that now?
I guess I read the 9.7 or something like that. Yeah.
9%. Very good. Congratulations.
Okay. Thank you very much, all.